everybody. Thanks so much for coming. I'm going to be presenting a paper that we recently submitted that's a theoretical paper, but also a comprehensive literature review of suicide drivers in order to differentiate between risk factors, warning signs, and drivers for suicide, and exactly why these sort of differentiations might be important for suicide prevention strategies. Within this talk, I'm hoping to answer some really important questions related to the suicide literature. Specifically, what suicide risk factors, warning signs, and drivers actually are, why they're different, why it matters. Also, what is the state of the literature regarding suicide drivers, which is a fairly new concept. And I'll present a systematic review, a comprehensive review, about the ability for suicide drivers to predict acute suicide risk. And also some questions about where the suicide driver literature should be heading and where some of the scholars are hoping to take this. As well as what we know about them now, how can they be integrated into suicide prevention strategies, as well as interventions for suicidality. Before I start answering any questions, though, I read this quote a couple of months ago from James Fowler in a theoretical paper about working with suicidal clients that I really liked. It says, as death rates decline for most medical conditions, suicide rates have risen approximately 60% over the last 45 years, with an estimated 1 million suicides worldwide. I thought this is really poignant, not only because it's obviously prevalent, but also in the same 45, 50 years, we've seen a boom in suicide research. The amount of people going into a career focused on suicidology. So not only our rates are increasing, it's despite the fact that we're having more people do some research and develop suicide prevention strategies, which begs this idea that maybe what we are doing is somehow not reaching the people it needs to reach the most. Again, a very poignant, a sadly poignant picture. This is right on the post of each post of the Golden Gate Bridge, and these are phones for people who are thinking about jumping off, that they can call and get hooked into a crisis counselor immediately. And kind of just like our field, maybe what we're doing isn't quite hitting the people that we need it to, just like this phone being, unfortunately, unoperational in the state that the picture was taken. It's not surprising with these increased rates of suicide over the last 45 years that a lot of research is focused on who is at risk for suicide. This makes a lot of sense. And they focus predominantly on characteristics that are associated with suicide risk, or risk factors. They're associated with the desire for suicide, suicide attempts, and actual death by suicide. And this research has really flooded suicidology over the last about 5 decades. And these suicide risk factors generally give us an idea of suicide risk throughout the lifetime. It doesn't give us a lot of temporal understanding of, although these characteristics are present, at what point is the suicide attempt or suicidal crises most likely to occur. Now, I will say, though, in the last maybe 5 to 10 years, some research looking at these risk factors have started to look at acute risk. Risk factors like insomnia and agitation have been shown to predict suicidal behavior within days in inpatient settings. But very, very few studies have tried to focus on this as far as risk factors. The risk factors receiving the most of the empirical literature, you guys have probably heard a lot of these, symptoms of depression, major depressive diagnoses. Dr. Wells had mentioned that about 50% of suicides seem to be attributable to symptoms of depression. I thought that was a real good synthesis of depression as a risk factor. Illicit substance abuse and use, alcohol abuse, as well as suicidal thinking, suicide ideation, practicing or preparing for suicide or practicing attempts, as well as previous suicide attempts. These are often our most researched risk factors in the literature and often getting used in suicide prevention strategies, as well as our kind of management and understanding of suicide risk. So this begs the question, why would 50 years of research on this not yield any sort of return on our suicide rate, if we're looking at this in almost an economic way? Well, there's a lot of potential understandings of this, but one clinical application is it may be that we're not really using our understanding of risk factors in a way clinically that's helpful. As there's 150 known risk factors in the literature, there doesn't seem to be any sort of algorithm of understanding these. If alcohol abuse and depression, but not insomnia, then what does that mean for risk? The general algorithm is the more present, the more likely. That's not exactly very sensitive of our ability to predict acute suicide risk. Similarly, what would be kind of a hot topic in the field right now is very few risk factors that actually can differentiate between those who are thinking about suicide and those who are actually going on to attempt. When we do mass testing data here at the university, we'll see about 30% of the college students tested will say that at some point they have given serious thought to ending their own lives. But when we look at the actual, have you attempted suicide, have you engaged in suicidal self-injury, that is well under 10% in that sample. And from when we're looking at very serious attempts, it's well under 2%. So we see that there's just very few people who actually ideate, go on to attempt suicide, and unfortunately our risk factors don't seem to be able to tell us who is likely to go through that progression from ideation to action. It's with that concern about risk factors in mind that in about mid-2000s, people started to focus on warning signs for suicide. Particularly David Rudd has done most of this work in this literature. And these warning signs are supposed to be similar factors that are able to show who is at that imminent risk or of acute suicidal crises. And I think the best analogy for this is the same way a factor of somebody experiencing arm pain, chest pain, and shortness of breath is an indicator of a heart attack or this is likely happening or going to occur. We're trying to find those sort of warning signs that we can see in individuals that demonstrate that that acute suicidal crisis or a suicide attempt is imminent and likely to occur. And the warning signs literature really came out of a synthesis of all the risk factors, as well as some really smart people at AAS, American Association of Suicidology, getting together, doing work groups. And they came up with this IS-PATH-WARM acronym that I know Dr. Wells thinks is funny as I do, that are supposed to demonstrate 10 of these sort of risk factors, characteristics associated with suicidal behavior that should predict or should demonstrate imminent suicide crises. And you see some repeat offenders on here, so suicide ideation, one we had talked about as a risk factor, but also things like hopelessness, anger, rapid changes in mood. So we're getting closer. Again, this is supposed to be the idea of being able to predict those acute suicide crises when an attempt is likely to happen soon. And again, why have these things that have been implemented in suicide prevention strategies not necessarily yielded a return? If you guys go into the clinic, you'll see little suicide lifeline cards in there. Open that one up next time you go. On the back side is the IS-PATH-WARM acronym. It's all over the place right now. But yet again, why are we potentially not seeing returns? Well, risk factors and warning signs seem to have similar limitations. Although they're supposed to do different things, yet again we have 10 characteristics without an algorithm of understanding these sort of interactions. What does ideation and purposefulness mean without mood change? Again, the more we experience, the more likely it is. And again, not terribly sensitive. As far as that ideation action framework, a recent study using, I think, a large alcohol dependence national data set demonstrated that only anger, so 1 out of 10 of these factors, can differentiate between current ideators who have had a suicide attempt and current ideators who have never displayed suicidal behavior. So at the crux of the matter, we have these warning signs that should show us who are likely to attempt suicide, but we're kind of batting 1 out of 10. We're batting 100 here. As somebody who's done that in their career, that ends up with you on the bench. Really, unfortunately, that was kind of how a lot of my college career worked. That was not optimal, is what I would say. I was pretty useless for those strands of time, and unfortunately, some people are worried about that for warning signs as well. So they're not doing what they're supposed to do, and we're potentially placing a high level of concern related to these warning signs. So then there are some other concerns about the overemphasis of warning signs, as they are supposed to predict acute suicidal crisis, but not necessarily are. Specifically, things like anxiety, social isolation, and anger and hostility. These things actually can wax and wane in individuals through the course of therapy, through their lives, through their daily, through their kind of days, all right? So if these things are dynamic and they may wax and wane, the overemphasis of warning signs that maybe cause us to make clinical predictions is a little problematic. There's the potential for iatrogenic concerns like forced and unnecessary hospitalization, as well as decisions about leave status for military personnel who may be experiencing things like rapid mood change or anxiety. Not surprisingly, we have a fairly large social stigma around suicide. A lot of research has shown this. And some scholars are really worried about the overemphasis on warning signs because it may actually increase people's likelihood to conceal these sort of warning signs and risk factors and potentially exacerbate the sort of mental health stigma we have in our country. And as you read this, I'll take my unplanned drink of water. So it's with the concerns with risk factors and warning signs in mind that some scholars, and really mainly David Jobs out of Catholic University, have tried to understand that maybe we're not looking at the factors incorrectly. Maybe it's not that depression isn't important. It's not insomnia isn't important. It's how it's getting translated into clinical practice is maybe where our problem is. Maybe we're not looking at these things idiographically enough and really contextualizing our clients' unique struggles in pain in relationship to these factors. So it's really the translation of how these are getting used and how they're getting implemented in clinical frameworks that may be part of the concern. And this is a really crucial aspect of the collaborative assessment and management of suicidology. And this is where we're actually starting to get into drivers. That understanding drivers of suicide may help us get a unique contextualization of our clients' concerns. CAMS is a therapeutic framework which emphasizes the patient and the provider working together to understand the suicide crises, what it means, and how to potentially prevent it. I'll give you a little bit of background on CAMS here in a second. It's really meant to enhance the therapeutic alliances. Sometimes suicide concerns in clients can almost be challenging to the clinician's work. The clinician can feel like it will almost be a challenge. There's some research on this sort of idea that helped Dr. Jobs continue to work on CAMS. So at the heart of CAMS are the idea of suicide drivers, which can be broken into direct and indirect drivers of suicide. So direct drivers of suicide are these idiosyncratic, so person-specific internal experiences, behaviors, and external situations that the patient is actually associating with their suicidal crises. And they've been thought of as person-specific warning signs. So taking into account somebody who comes into our clinic, potentially after a suicide attempt, and says, the reason I attempted suicide that day was because I really felt like the people in my life would just simply be better off without me. In this case, that sort of perceptions of burdensomeness may be the driver behind that suicide attempt. Indirect drivers can be very similar experiences. There's really no difference in the characteristics, but the patient's not actually associating this with his or her suicidal crisis. But in sort of a conceptualization, we can see where these things may contribute to the etiology and the maintenance of the driver, as well as the belief that life isn't worth living. So this individual that has attempted suicide for these perceptions of burdensomeness, an indirect driver may be financial hardships, losing a job recently, these sort of things that may have contributed to the development and etiology of the direct drivers and the belief that life isn't worth living. Now, I won't go into too much about CAMS because that could be a full study in and of itself, but just to give you an idea of what this evidence-based practice looks like, it starts with a thorough assessment of a patient's suicidality through an initial screening session. And subsequent sessions include the tracking of suicidality through very specific forms, creating a crisis response plan, which often involves things like suicide safety plans, a lot of what we may be doing already, as well as treatment planning, collaborative treatment planning, and the reduction of these suicide drivers. And when CAMS would technically be disbanded or be terminated, it's when suicide ideation has been resolved, which Dr. Jobs operationally defines as 3 consecutive sessions without suicidal coping is present. So one of the big crux of this is this idea that suicide drivers should be looked at and it should be discussed and try to decrease through treatment planning. And thus seems to be these patient-specific warning signs that can help us understand when our clients are more likely to make a suicide attempt through the course of treatment. Not surprisingly, the drivers are beginning to get some research in the literature. Specifically, 5 drivers are often assessed in CAMS, as well as open-ended questions for people's drivers can be discussed. But 5 that have been most often looked at, the psychological pain, stress, agitation, hopelessness, and self-hate. These have all kind of been distilled from theoretical frameworks of understanding of suicide as early back as the early 1900s, where psychological pain was first kind of getting talked about theoretically as a model of understanding suicide. So this led our research team to have one really important question that we wanted to answer, and that is, what sort of drivers of suicide that are modified by psychological intervention actually predict suicide attempts and death? If these things are supposed to be person-specific warning signs demonstrating acute suicide risk, which ones in the literature are showing to actually do this? And similarly, do these drivers identified in the literature map onto all these decades of research about risk factors and warning signs? Basically, are we spending our time and our money looking at the right characteristics that might be most important to understanding suicidal behavior? And so we completed a comprehensive review of the suicide driver literature, trying to understand these questions. So we searched Medline and PsycInfo with suicide and drive as our search criteria, as well as the iterations of both of those. And this yielded 148 articles for review. We used a two-step review process where we looked for our inclusion-exclusion criteria through the abstract, and if it was met or it was kind of hard to tell if it would be met, we would go on to a full-text review where we reviewed the entire article. And unfortunately, in our literature review, oh, excuse me, I'm one ahead of myself. I should probably tell you what we included in the review. Hopefully, this shows you how we're trying to answer those questions through the literature review. We needed to see articles that were published in English over the last 20 years. So this was between 1992 and 2012. We're looking for adult clinical samples, as we're looking for these sort of drivers that predict acute suicide risk. So we're looking for more severe clinical samples. One of the primary outcomes should be suicide attempts or death by suicide. It should assess some sort of modifiable driver for suicide. And we try to keep this reasonable in the sense of anything that seems to be, could be a target of intervention through psychological intervention, something like perceptions of burdensomeness, depression, that an evidence-based practice reasonably could work with. Where something like gender, which we know predicts suicide attempts differentially, is something that's not necessarily psychologically modified. We use original quantitative data, and we're looking for original quantitative data presented through case control, case series, experimental, and meta-analytic strategies. We also did include psychological autopsy, as of course those individuals were looking at people who have died by suicide, and that was an important concept as well for this literature review. And that was disappointing. We found nothing, absolutely nothing. So we're doing this work, and we're sitting down, we're trying to understand why we found nothing. And one of the arguments might be, well, CAMS is fairly new, so the idea of drivers might be new. We also know that in our suicide field, we have a real awful terminology problem, that the idea of suicide and suicidal thinking and attempts and behavior often mean a lot to different research groups. We've had focus groups at conferences try to give us, these are the terminologies we should be using. So we thought that maybe at some point in our history, we've actually been assessing drivers without calling them drivers. So maybe some people have done research with risk factors of suicide and assessed them in a way of these risk factors actually drove suicidal crises in this study. So we decided to broaden our search criteria, which was a great idea at the time. I'll explain to you why. We included other iterations of words such as theory, cause, predict, and risk factor. And if any of you guys were around in about 2012, you realize that this is the time I started not appearing socially, because we found 3,000 articles, because we're basically trying to do a systematic review of the risk factor literature. And that's not an easy thing to do. There's a lot of reasons why people don't do this. But we did find over 3,000 abstracts to review. After almost a year of going through those, we had over 350 articles for full text review to complete the review process. And here's what we found. Well, no articles actually demonstrated drivers predicting future suicide attempts or past suicidal behavior. This is good. We replicated our first one, right? Because if we didn't here, we would have been pretty frustrated. Similarly, no articles prospectively predicted death by suicide, or there weren't any sort of case, psychological autopsy studies that did this as well. And why we broadened our search criteria, try to get this idea of maybe risk factors were assessed in a driver way. Not a single one of those either. So we got through all of these articles, and the 4 researchers on this study, after going through the review of these articles independently and together, demonstrated that really none of these studies that were looking at suicide attempts were actually analyzing data in a way that's consistent with drivers. There were characteristics that predict suicide attempts and suicide death, but there was no data really demonstrating what was actually driving the suicide attempt according to the suicide attempter. And that's the important part of CAMS and drivers literature. So what sort of research do you get future directions off of? Nothing, literally nothing. I think that demonstrates really one important thing, that we need to find out, does the assessment of suicide drivers actually help our ability to predict acute suicidal crises in our patients? Because this is such an integral part of CAMS, which is receiving some great support through randomized control trials, but at the crux of it, do these assessment drivers really help us at all? And similarly, that the field is really trying to look at who progresses from ideation to action. Do drivers, an assessment of drivers, actually help us to do this? I also really like Connor's slide about theory refinement, and I think drivers looking at our risk factors within our theoretical models through a driver lens may provide us some input about theories of suicide that may be important. And since 2005, we've seen a boom of theoretical models for suicide, and now people are testing competing models, they're testing how they should be changed. So there may be ways of understanding ways to change and implement Joiner's theory to understanding which of these variables, risk factors, may be the drivers of suicide in some individuals and why that might be important. Similarly, the integrated motivational volitional model of suicide discusses at the heart of it the motivation for suicide comes from feelings of defeat, entrapment, and humiliation. But again, understanding these through what's actually driving the suicide attempt may help through model refinement. And similarly, the cognitive theory of suicide discusses perceptions of unbearability of living and hopelessness as psychological disturbances that are related to suicide. That continuing to investigate these through a driver's lens can actually understand how some of these things may interact differentially and could be important for theory refinement. As far as clinically what we know about drivers, well, it's not showing us a whole lot about our ability to predict suicide risk. We did find in randomized control trials of these idiosyncratic stories that are being told through suicide drivers does seem to increase rapport, or seem to be related to increased rapport between clients and therapists. So continuing to use these idiosyncratic stories of suicidal crisis can be helpful. Some scholars are arguing that the diagramming of the individual suicide model or the suicide mode might be helpful through things like functional analysis, behavioral chain analysis, and using the suicide status form. I'm getting a lot of blank looks, so I won't show you the suicide status form now, but I'd be happy to show it to you at some other point, and how that can assist in that. As well as the collaborative create and stabilization plan and therapeutic plans of reducing drivers as a way of guiding treatment and assessing the progress of treatment throughout. So I gave some thank yous real quick. Kevin Crowley, who's at the Capital Institute for Cognitive Therapy, that handsome devil in the middle, Colin Davidson, who's now at Hennepin Medical Center, and Pete Gutierrez, who's at the Denver MIREC, for their help on this paper. Any questions? Yeah.
We didn't plan this. This isn't a softball. If you're suggesting that drivers are, as you look at them ideographically or person-centered, so there would be I guess you could describe it as a unique algorithm for each person in order to predict suicide, then how would you use them to predict suicide in the by the masses? It seems like you'd have to do it pretty at an independent basis then.
Yeah, and there may be methodologies that can assist with that. And there is a big push, not a terribly big push, but a push in the literature of still N=1 case designs and doing so rigorously. Matt Knock and I think Kevin Barlow just